Hi, good morning everyone. Today I would like to talk about initial assessment in adult. I think most of the artists are working in adult sectors, adult ICUs. So just ICU and wards, adult sects. Very rare where artists only is working in the pediatric sessions. Just I will go through the just basics of the assessment for especially for the students. It will help actually. Just I will go the format how whatever these things you have to do, how you have to be how to take interview, all those things. Today I am just talking some few points. Preparing for the patient encounter, the medical history, and the interview, then cardiopulmonary symptoms, then vital signs, then physical examination and neurological assessment. As a respiratory therapist, you should be able to interpret and recognize perform the right patient assessment the procedure that will be lead to the appearance care for the patient. You will also need to be able to make therapeutical recommendations such as administrative therapy in effective manners. Then evaluate the patient's progress as well, recognize any adverse reactions. First, you have to see the doctor's order. When you are going to see the patients, before seeing the patients, you have to see the doctor's order. What their advice, what is their want, the patient's what is requirement. First, you have to see that. Then, when you are going to the patients preparing for the patient encounter. The patient-centered care founded on two-way partnership between provider and patient. The quality of interaction between patient and care providers is at the heart of effective patients centered care. Minimize medical error contributes to enhanced patient safety. Three main elements, just I will go through the main elements. It is individualized care and provide collaboration patient involvement. First individualized care, empathetic communications. Then respect patient for the patient values, then sensitive to culture's values. And when it is going to provide collaborations, communications, then coordination, then share responsibility. Then patient involvement, patient education, shared decisions making, patients' participations in the care. The medical history and interview. That is a very important thing is when you are going to the patient side. You should know how to take an interview, how to listen to the patients. All those things you should know. The history is the foundation of patient's assessment. A recorded picture of the patient's perceptions of her health status, current problem and effective of treatment. If comprehensive subject data information that the patient's report feels experience that cannot be perceived by the observer. With skillful obtain the history of contribution in a significant way to the occur diagnosis. Before going to the patient side, you should do hand washing. Then first thing it is when you are going to the patient's room, where you are seeing the patients. First you have to wear the mask and you have to be sterile. Then you have to do the proper hand washing. Then you have to go inside the patient's room. When it is enter the patient's room, you should have interviewing skills required practice and are an important part of patient assessment for the healthcare providers. The ability of the interviewer to project a sense of undivided interest in the patient is the key to a successful interview and the development of good patient's reports. One of the most common mistakes made by interviewer is failing to listening carefully to the patient's answer and questions. When you are going to the patient side, it is you should first when you are asking if you ask some questions like what is for example, if just you are taking the clinical history, some the symptoms, anything. Just when you ask the questions, you should listen first. What is their answer? You should carefully and you should listen what they are saying. That is very important things. It is cardiopulmonary history. Abnormalities of the respiratory system frequently reflect other system disease process. Therefore, cardiopulmonary assessment cannot be limited to the chest. And complete evaluate of the patient entire health status is essential. The outline of complete health history. Just I will go through the format. What you have to do. What is the format? How to take the patient's history. How to take what else you have to take data. First you have to so demographic data. So like for example, name, address, age, like over then race, nationalities. Then next step is you have to data source. Data and source. Data and source is history, estimation, history reliability, and the patient seems to be good, fair. Then next is brief description. Patient's condition at the time of history or patient's profile. Then you have to go for the chief complaints, reason for seeking health care. Then fifth one is the history of present illness. What is the present illness you have to take? Onset time, source settings, frequency and durations and location of and radiations and severities, then quality, then aggravations, then associate manifestation. The sixth point is just past history and medical history. When you are taking the history, very carefully you have to ask the past history. What is childhood disease like development? Then here hospitalization, any surgeries done before, any accident recently, any other major illness. Just you have to see all those. You have to go and you have to take a past history. Then you just next you have to see the allergies. Any patients having any allergy for the medications, any other. Then you have to ask the medications. What is any regular medications? Past any regular medications is taking or not. Then you have to see the immunizations also. Then next step is you have to see the family history. When you are taking the family history, is to have to see, for example, in your father's mother, just patient's mother, grandmother is having diabetic or hypertension. So there is a chance to get continuous. Like for respiratory side, if you say respiratory side, it is like allergic asthma. So there is a chance to get next generation, like your son, daughter. So there is a chance to spread that next generation also that allergic asthma. So like that, family history is very important diagnosis. So then family relationship you have to ask. Then social environment history, education, then review of the system. Then you have to go through this, then you have to signature, everything, once you take everything, all the data, then you have to give your signature. Then whether any subjective information from the patient. The cardiopulmonary symptoms, just tell about the cardiopulmonary symptoms. Symptoms are objective clinically findings generally reported by the patients during or shortly often is the essential interview. Clinical signs on the other hand are objective and measurable, such as vital signs and laboratory studies. The primary symptoms associated with the cardiopulmonary disease are cough, sputum productions and hematitesis and shortness of breath, then chest pain. Way of cardiopulmonary symptoms are assessed. The seriousness of the patient's problems, the potential underlying cause of the problem, then effectiveness of treatment, then you just sudden personality changes or alteration in mental status and indicative of an acute problems. The patients who suddenly becomes restless deserve the same something investigation as the patients who becomes less responsive. Then next you go to when you are checking the vitals. Now it is go to the objective information from the patients, like for the example vitals. When you are going to the vitals, just you have to see saturation, then pulse rate, then respiratory rate, BP, all the things you have to see. Then vital signs should be monitored, recorded of often as necessary for the safety of the patients. In the frequency which is patients' vital signs are assessed in detected by the acute or degree of illness, with those of more accurately ill patients being assessed more frequently. Then next, physical examinations. Physical examination is nothing, just is the process examination the patients for physical signs of disease. Effective way to obtain immediate and pertinent information the patient's health status. Then it is for the, just I will go through the basic components of physical examination. I think it is first session it is explained about inspection, palpation and percussion auscultation. It is already taken by first block, so I am not going to the deep. So the next step it is like a typical formation for recording the physical examination. First thing it is you have to initial impression. For example, just you have to take a patient height, weight, general appearance, and then vital signs. What I said, it is like pulse rate, saturations, then heat examinations like head, ear, nose, and throat. All examination you have to do. Then inspection findings. Then neck inspection and palpation findings. Then you go to the thorax. Thorax, what you have to see? You have to see the chest and heart. So just lens, you have to, whatever you have to see in the lens, you have to do inspection, you have to do palpation, then you have to do percussion and auscultation findings. Then if it is go to the heart, what you have to do you have to check the inside, you have to do the inspection, then palpation and auscultation findings. Then you have to go to the abdominal examinations. With abdomen, you are going to the abdominal examination just to go for inspection, just to do the inspection and palpation, percussion and auscultation findings. Then extremities, inspection and palpation findings. Then it is we are going to the neurological assessment. It is very important. As a respiratory therapist, it is very important. The comprehensive evaluation of the mental status, cranial nerve functions, motor system, coordination, sensory system, and various reflex. The injuries that involve the nerve system often affect a patient's respiratory system and the ability to cooperate with respiratory care procedures. Thus, the RT should be familiar with the key of components of the neurological assessment, especially when managing the critical ill patients. The frequency and depth of neurological assessments depends on the patient's diagnosis, acuity of the conditions, and how rapidly changes are occurring or expected to occur. Many neurological functions of particularly importance to the RTs, such as regulation of heart rate, blood pressure, and breathing, are located in the brain stem. The perinix nerve system arise from the cervical spine roots of CF3 and C3 to C5, and damage to this portion of the spinal cord can result in complete paralysis of the respiratory muscles and ventilated dependency. Then next you have to see the GCS. GCS, it is like if it is go less than 18, less than 8, then you have to go for intubations. You have to give airway support, airway management. The patients with the neurological disorders can result in abdominal respiratory patterns. The most common among is chain stocks respirations. Assess the gag reflex, the ability to cough, breathing patterns, then ICP brain death, then will be and etc. Then will be indicate the importance of monitor neurological status in critical ill patient. Use these informations that you gather, develop a plan of the care, then time to plan. Just when you are going to the patient side, you should know the basics of what are the format you should follow. Just I go to previous slides. That you should know the format, how to take histories, how to take patients' vitals. You should keep the formal like it is standard formality. So you should know the when you just patient, you are going to the patient side also, you should know how to take care of the patients, how to listen to the patient. So everything you should know. Then format also you should know the what is the first you have to take, what is the second step as a students when you are going to the clinical side or posting side. You have to you should not take like something like patient is having asthma, like a patient has been COPD. No, this is not like first you have to when you are going to the proper way. Is you have to follow the format. It's like for examples, you have to go through the first things like patient's name, age, everything you have to write it. Then you have to step by step you have to go. So it is you follow the format. It is a very standard format you have to follow. I think this is just for the basic lecture for the especially for the students. I think hope you all understood. Any doubts or anything, just okay. Thank you. Thank you so much.
Pleased to hand over the momentum. Anjali, Treasurer of IARC, to come up on the stage to hand over the momentum. We regret you to inform the absence of Dr. Harish that he is not keeping well. Wishing him a speedy recovery, but he has sent a video recording of his talk. Let's have a look on it.
I am here. Any questions?
I request Dr. Harish to come up on the dais.
Morning all. Happy to see the huge crowd here. Myself, Dr. Harish. So because of some personal reasons, I could not deliver the lecture physically. So this is one important aspect. Like we know that when a patient came, got ventilated, so our main intention is to save the lungs, save the lung-associated injury which have an impact, means systemic impact, means like when the injury started, the biomarkers which released, so the cytokines which released from the lung, they are going to distribute it throughout the body, so which have an impact on the organ dysfunction, multi-organ dysfunction, so increase in mortality and all. But other hand, we need to understand how we can tackle and prevent this ventilator-associated lung injury. This is a brief overview on that. So any questions, I am happy to answer.
If anyone have questions, please raise your hand. I'll give you the mic.
The concepts also evolving in and around this ventilator-induced lung injury. So one a small part which I have not covered is like there are some additional advanced modes of ventilation. Like you are aware APR, airway pressure relief ventilation and all. So that is a literally an inverse ratio ventilation. Okay. So that is also meant and proposed and marketed in view of reducing the ventilator-induced lung injury. Lots of data is coming even post-pandemic. So even in some countries they used this APRV mode as one of the modality to reduce the ventilator-induced lung injury in Canada and all. So that is one thing I can remember. So some modes of ventilation directly proposed to reduce this VD. So thank you all the best.
Thank you, sir.
So we all must be tired. Let's take a deep breath and meet up for the inauguration function. Thank you.
An immense pleasure. We feel privileged to extend a warm welcome to all presented here for the third regional conference, RESCONS 2020 of Indian Association of Respiratory Care in association with Apollo Hospitals. Academical program, this annual symposium which proceeds since 2016. Now I request Dr. Ravindra Mehta, our Chief Interventional Pulmonologist, to kindly occupy the chair on the dais. Thank you, sir. I request Ms. Anmol Thorbole to present the momentum to sir. Dr. Govindaya Yatish, COO of Apollo Hospitals, to kindly occupy the seat on the dais.
Thank you, sir. Now I request Dr. Jerry Paul, President, Indian Association of Respiratory Care, Head Department of Anesthesia, to kindly occupy the chair on the dais.
Thank you, sir. Now I request Dr. Harish, intensivist, Narayana Hrudayalaya, Bangalore, to kindly occupy the chair on the dais.
Thank you, sir. Now I request Mr. Sharif, Organizing Secretary, to occupy the chair on the dais.
Thank you, sir. Now I request Ms. Anmol, Organizing Chairperson, to kindly occupy the seat on the dais. Thank you, ma'am. We request all the dignitaries to do the lamp lighting.
Hello? Thank you, everyone. Kindly occupy your seats.
Now we request Ms. Anmol to deliver the welcome speech.
Good morning all. It is my pleasure to welcome you all, the participants for today for the one-day symposium Respond 2022. I welcome all the eminent speakers and the guests from all over the Karnataka region from different walks of life who have come here to share the knowledge and the vast experience with the student community. This is the first offline conference after the pandemic. This pandemic has brought our profession into the limelight, and we all know we have worked day in and out as a frontline workers. Please put a round of applause for all the working artists. I would like to appreciate and thank everyone who came here and led up to this day. We are proud to announce that this conference is being conducted along with the cooperation of Apollo Hospital, who has been pioneer in healthcare for past 4 decades. On behalf of Indian Association of Respiratory Care and Apollo Hospitals, I welcome all for the Respond conference. Please enjoy.
We would like to listen few words from Dr. Ravindra Mehta. Dr. Mehta is Chief of Interventional Pulmonology, Pulmonology and Critical Care. He is also the Chief of Apollo Hospitals, Bangalore, Advanced Pulmonary Services. Sir, please come over, sir.
Thanks a lot. There's a mic on the desk. It's always nice to talk. There's a much better view. So it's actually amazing, overwhelming, because this is the return of the new normal, as they call it, or the good new normal. We call the new normal in COVID when people were used to this online business and all. We reluctantly adjusted to it, but none of us liked it, let's face it. The happy faces, the energy, the large attendance, and every seat full speaks volumes for itself. So congratulations on A, having a on-site meeting of such magnitude, and B, to a lovely society, and C, of course, the organizers, spearheaded by Anmol and her, and the society which has allowed this to happen. So my congratulations to all of you. The second is, where do we put this in perspective? So if I can take a few lines over here, respiratory therapy. Basically something which is mentioned, which is talked about, very well respected in the Western world. No doubt, the respiratory therapy leaders of the Western world are so good in their understanding, they beat a lot of us doctors in our part of the world. But in India, it's taken time. It's really, really taken time. The acknowledgement of the amazing role played by you, the lack of understanding of the medical community that there is a technological revolution taking place in the ICU, the wards, in procedures and so on, which needs the right support. It needs a community of people who are smart, savvy, who are focused on this, who understand this, who have the energy to do this, the patience to do this, and take this technology and improve it. So the world at large, the medical world at large, has not actually recognized it. But all of us in the ICU and my colleagues here will admit that it is invaluable. Ladies and gentlemen, your role is invaluable. You are such an integral and important part of the team that truthfully it's like driving a car without one wheel if we try to go on this juggernaut of modern critical care without respiratory therapists. So few of us acknowledged it. A lot of us were grudgingly accepting it. But the community at large, the organizations at large were not giving it the importance it deserved. And then came this game changer. Anmol touched on it. The game changer is a 5-letter word which shook us, shook the world, shook the global community, and even made presidents who look brilliant come to their feet. COVID-19. And COVID-19 hit us like never before. All of us went through denial, complete rejection, putting our head in the sand like a stork and hoping it would go away. COVID was non-forgiving. It was, for those of us who are philosophical, it was an act by the maker to tell us that when things come, you have to get your act into shape. What happened over here? This silent, hard-working community, which is represented by so many of you in this room, suddenly became of importance. The scramble for people who could handle technology and take care of these patients suddenly went up onto center stage. Never in our life have we seen full hospitals. For example, our entire hospital was converted to COVID. Never in our life have we seen one hospital, one diagnosis, and maybe with luck we'll never see it again. Never in our life have we seen the need for so many machines. Never in our life have we seen so many young patients sitting helplessly waiting without families, without support. Here, the teams which worked were so important. And in that collection of people who had to make this happen, one lot of angels stood out. You guys, there is no doubt about it. Those of us who were naive expected those nurses who were sitting in PP, worried about what their parents saying, come back home, not concerned, outcomes going bad, putting on ventilators when the risk of aerosol. So many of us expected those nurses to do it. Guess what, ladies and gentlemen? If you wanted to ensure outcomes and you wanted to send my brother or my father home, that was not going to happen. You needed people who were technologically savvy, who knew how to handle the machines, who could take care of the people with the machines, who could rally around and give support in ICUs and wards in the community, and who could actually even go to the community and get these machines in, and most importantly, manage these in the community when we had no beds at all. Such a function was impossible to subserve or to completely ad-lib them in a crisis like COVID-19 when you had less than 3 days. Dr. Yatish gets a call from the government that in 3 days flat we need a hospital. There was no options, there was no other mandate given. How could we do this? And this is where your community, and I will not only acknowledge it, I bow my head and I will say it in any forum, God, we needed you guys. And like the angels of which were given by the Lord, He gives you a problem, He gives you a solution. We repurposed, we got everybody in. A young workforce came onto the ground in our hospital as it did in most hospitals represented by you guys. And many lives have been saved because of the unique contribution, energy, and unparalleled effort of this community. And that has brought it to center stage. So I'm very proud to say this is not a conference. It is a reminder that the age has come for people to acknowledge your role. The time has come for people to understand that we cannot work without you. Your role is an integral part of intensive care wards and so many other areas. This is now something which has come onto center stage. This is respiratory therapy version 2.0 because we're an IT city. And this, with great happiness I say, shows that this young community can actually add to patient care in critical areas like never before. So with this compliment, heartfelt, this acknowledgement of your role, this need for a horrible entity like COVID to actually get onto center stage, we laud you for coming here. And we absolutely appreciative of your need to acquire knowledge. And I see the next few years are going to be the age of respiratory therapy, contributing in a way like never seen before. Thank you very much and have a great day.
Thank you, sir. I request Ms. Anmol Torbole to hand over the memento to Dr. Mehta. Thank you, sir. I request Dr. Govindaya Yatish to address the audience.
And good evening to all. I think Dr. Mehta has already took across everything, but I want to say a couple of small few things. We need to empower you. You are the one who are always day in, day out in the ICUs and in the ward, both taking care of non-invasive to invasive. Thing is, I want to tell you guys about my experience of about 18 years in the hospital health care. There's a huge difference between what level of critical care we deliver in South in India to what is there in the North. I hardly see any respiratory therapist in the North. I think it's our duty, it's the time for all of us. Particularly I request the Critical Care Society, mainly Respiratory Society, you guys need to be the integral part of respiratory critical care. And that is something I feel when Anmol came and said we want to do it, I said please go ahead and do it. Thing is, not even any one word thought about what's going to happen, how it is and all. I know that the country needs it, and I know that if we are not as a leaders, we are not supporting and empowering this community and the upcoming professionals, we are not being there. So that is the first thing what we felt, and the amount of work you guys did. Thing is, we sincerely, one is empowerment, second is the gratitude. Thing is, so many machines, all our ICUs, 35 ICU beds are all connected hooked to the machines. As Dr. Mehta said, not only in the ICU, we started getting into the ward, and then not only into the ward, we started getting into the community. So your role is not just only in the hospital ICU care, your role is there in the home. At the same time, the last and the least, I want to say, wherever you want to practice, please look at think about protocols, think about patient safety. Yes, upskill yourself, watch for the warning signs, take care of necessary precautions. It's the reason because the world is a litigant world, right? That what also I want to highlight it. Thing is, every time please cover your back with the help of clinicians, and they're all there, they are literally dependent on all of you. Good nursing team, you are working with them as one cohesive force. A good harmonious relationship with the nursing staff and the respiratory therapist and the intensivist, it is going to deliver the highest standard of quality care. I wish you all the best, and we look forward to see such more conferences. I want to see debate between the respiratory settings happening in the ICU, between the intensivists, the residents, the registrars, and to the nursing staff. And end of the day, it is all about for the patient and safe patient care. Thank you. Wish you all the best. Thank you.
Thank you, sir. Now I request Mr. Sharif to hand over the momentum to sir. Dr. Jerry Paul, President, Indian Association of Respiratory Care, Head Department of Anesthesia, Kochi, to speak few words.
I'll make a small correction. I'm not the chief, okay? The chief is Dr. Lakshmi Kumar. I'm second line, okay? Our chief patron, Dr. Mehta. CEO of Apollo Hospital, Govindaya Yatish. Dr. Harish Emam, editor of IJC. Anmol, the organizing chairperson, Mr. Sharif, the organizing secretary. It was actually an honor to be here. When I was invited, I was kind of wondering whether there would be anybody around. But I hear that the registrations crossed 300, which is wonderful. Now, it's also a very wonderful event for the respiratory therapist. In Kerala, if you organize one, we have to get people from all over the world to fill the hall. Okay. So now I see that so many of you are, so many students, so many people working in multi-specialty hospitals. And your recognition is what Apollo has done for you today, okay, by sponsoring this particular meeting. It's heartening to see such a big crowd. Now I'm sure the students will have a lot of questions as to what happens after you do your basic degree. You have so many diverse that you could go into. You can either go into intensive care. Okay. You can go into, you can go and connect yourself with a pulmonologist. In fact, we have a pulmonologist, a pediatric pulmonologist, who employs respiratory therapists throughout. And I hear that he does all the ICU work. Because he's so busy, the physician is so busy that the entire responsibility in the ICU is given over to the respiratory therapist. And you can see what you are capable of doing when you are given the kind of environment and the responsibilities. You could go into rehab. I hear there are people doing completely rehab around here. Okay. Or you could also connect yourself with some sort of an industry and even start a business of your own. So those are the possibilities that you have, such large possibilities. And your organization, IARC, is putting all the energy into trying to set up some sort of a curriculum which is standardized across, so that you follow the same kind of a, they've created a comprehensive program, and they're also trying to create some kind of structure so that it is followed across all over. And remember, your potential is unbelievable. I can give you some examples. A few years back, I come from an anesthesia background and I've done my intensive care fellowship also. So I was doing intensive care at that time. And there was a trauma patient. It's a lady in her 40s. What happened was the husband, the wife, they were taking the son to the railway station. There was an accident, the husband died. The son had serious injuries and the mother landed up in RIC. Okay. She did not have any structural lung disease, absolutely nothing. She had no trauma to the lung. But for some reason, we just couldn't be. I would speak to the nurse to bring down the support. Okay, we give the instruction, okay, do this slowly and let's see what happens. And we go back to our work. By the time we come back, we see that she's on full support again. They'll say the patient stopped breathing and we had to put the patient back on this. Now this went on for several days. We tried extubating in the patient, went back on ventilator. Finally, she landed up on a tracheostomy. Still, we couldn't make wean. We wean and put on breast support and put her on some TPs or something, she'd go back to the complete support again. So I called up the RT. At that time, RT was not covering my ICU. So I called them up and told them the problem. You know what they did? They employed 3 of their senior RTs. They made them stay there around the clock. After about 24 hours, he came and said, "Sir, she's ready to come off the ventilator." Okay. I was kind of surprised. Why couldn't I or the nurses do that? That happened only because they were around the clock. They were watching the patient, what was happening, and they were able to get the patient off. The first time we used APRV, and Dr. Harish was talking about APRV, that was again a few years back. There was an Australian nurse who came for infertility treatment in Kerala. She developed ovarian hyperstimulation syndrome. So, that being a gynec patient, it came to our ICU because we cover that side also. Now what happened was the lung is white, absolutely white. What do we do? So we thought, I had just gone through the APRV and learned about it a little bit, so I thought we'll try doing it. I spoke to the respiratory therapist. They said, we'll do it. So they sat down, we made a program, and we decided what the pressure was required and everything, and we set the thing up. The problem is, in APRV, only you know how to do it. If you ask the other people to do who's not familiar with it, it becomes totally confusing because it needs the patient to be completely spontaneous. We need to know how to set up the pressures, the pattern pressure to choose, okay, the releases to be set, all those things. So it can be a little confusing. So if something goes wrong, to switch to another mode becomes a bit of a problem for people. Okay. You know what they did? They stood around the clock. They made sure the patient was ventilated. She was weaned over a 3-day or 4-day period, and the lung had absolutely cleared. How do I say that? In fact, they did a CT after this. And there was a small sheet of atelectasis in the lung, other than everything is okay. So we did APRV also. You understood? So if you start APRV early in ARDS or any such situation that you do it actually protects it. It protects the lung absolutely. So remember that you are the people who do it. Right? You are the guys who can do it. So, and in the future, right now it is just catching up in many other centers where they don't actually recognize your importance because they don't know what you do. Okay. In the near future, what I'm seeing is, I will see every hospital with respiratory therapist manning the ICU, and that actually brings down our burden of the physician. And also remember, you are not acting independently. You are always a part of a big team, a team where it's called multidisciplinary approach to a patient. Okay, so there's a physician, there's a nurse, there's a therapist taking care of the ventilation, oxygenation part. So that is how it's going to be in the future. Okay, so that's what I see. So don't get disheartened. Many of us do get disheartened when you go through the BSc. Why am I studying this? Why am I doing this? Okay, so try and get attached to a good hospital, get trained, and then you can actually see the immense potential that is there. Right? So wishing you all the best, and it's a wonderful conference, it's a wonderful academic session. Listen to it and take it to heart, and all the best.
Thank you, sir. Now I request Ms. Anmol to hand over the memento to sir. Dr. Harish M.M., intensivist, Narayana Hrudayalaya, Bangalore, to say a few words.
Good morning all. Happy to see such a good crowd here. So it is definitely more than the crowd currently which is happening in many of the super specialty conferences and all. So very enthusiastic people here. So I just want to share like how in the last 1 decade respiratory therapy evolved as a recognized allied health science. Maybe half a decade back, so when I used to sit for the interview in the like entry level for BSc respiratory therapy and all. So after they given their entrance exam, we used to conduct some sort of formal interview. If you ask them like why you are joining respiratory therapy, sir, I am not getting any other allied health science, so I just want to try respiratory therapy kind of stuff. But in the last 6-7 years, currently in the last 2 years, so they come up with the mentality, okay, I want to do respiratory therapy. And so someone who missed because of the marginal, some because of less marks and all, they used to call me, sir, I really want to do respiratory therapy, can you do something kind of stuff. So definitely this branch evolved with a good recognition. So when in the beginning, in the 6-7 years back and also it's been respiratory care, named as respiratory care, and we struggled to make it as a respiratory therapy with a recognized allied health science and all. So like Indian Association of Respiratory Care, they had some sort of MOU with the government of India, so that Allied Health Association and all, so it has become a proper recognized allied health science course now. So you have an option for BSc, MSc in respiratory therapy. See, one thing I just want to suggest is you need to develop your some sort of professional growth with the aspect of research also, because being an editor-in-chief for Indian Journal of Respiratory Care, See, I expect lots of some sort of original research, maybe a observational study, auditing and all from the respiratory therapy members. Then you attach your name with some of the like intensivist or maybe an anesthetist and all. You take a help, but you keep coming with some sort of research ideas. There is lots of scope. So you have your own journal. So along with the patient care, hand in hand, to develop even your own professional some sort of CV with a good publication, good research work and all. So there are lots of things, lots of confusion at the bedside. If you see, like 6-7 years back, so at the bedside there was no role defined. Okay, so you have a physiotherapist, you have a nursing at the bedside and a respiratory therapy. We don't know like whom to call and all. So at the end of the day, so patient care, patient safety is very, very important. So we come up with lots of like SOPs. So what the roles and responsibilities of the respiratory therapist to avoid the confusion and also lots of some sort of blame game used to happen. So 5-6 years back. So we are in the era. So it has been clearly defined. Okay, so what exactly a respiratory therapist is having for the patient care and all. So including a developing of weaning protocol, so extubation protocol, decannulation protocol. So we created lots of checklists in our institute and all. So this branch is evolving maybe in the next decade. So lots of things are going to happen. So now it is being stick to some sort of South Indian major, some sort of like corporate institutes and all. So we have a tie-up with Indian Association of Respiratory Care with the ISCCM, Indian Society of Critical Care Medicine. So we created 1 year parallel courses after BSc Respiratory Therapy to have some knowledge accreditation respiratory therapy with the critical care medicine and all. So that also you people can opt. So definitely it's going to spread pan-India, so as Dr. Mehta told. So no doubt it is one of the very well recognized allied health science branch in the Western countries, but it's going to happen in India also. So all the best for your conference. Do well in your career. So commit yourself for the patient care and overall the safety of the patient. Thank you.
Thank you, sir. I request Mr. Sharif to hand over the memento to sir.
Hello.
Deliver the vote of thanks. Thank you, Mr. Sharif. I request Mr. Lokesh to hand over the memento to Sharif. Vishnu to hand over the memento to Anmol. Moving on, we have the prize distribution for the poster presentations. The runners for the poster presentation goes to Miss Blessy. I request Dr. Jerry Paul to give away the prizes. The first prize goes to Nishita R and Sanjana Pujari. I request Dr. Ravindra Mehta to hand over the prize. Kindly request everyone to maintain silence and put your phone on a silent mode. Yeah?
Good morning all. I am Duna Anas.
We feel on behalf of Apollo Hospitals and Indian Association of Respiratory Care, who has clubbed all of us three for the 3rd Regional Conference of Bangalore ResCon. We all are attending our first physical conference today, almost after 3 years due to the pandemic. Before we begin, we would like everyone to give a round of applause for all the respiratory therapists who has worked as a frontline workers during the COVID. Thank you all and keep up the spirits high.
In ResCon 22, one-day symposium, we will be lectured by various faculties from various specialities. Let us start our day with how we will initially assess pediatric. This topic will be lectured by Miss Ummi Salma. She has been graduated from Manipal Academy of Higher Education. Currently, she is working as Senior Respiratory Therapist in Pediatric Cardiac ICU at Narayana Hrudayalaya, Vammasandra. Miss Ummi Salma, please take over the scene.
Good morning, Bangalore. Thank you for the introduction. Okay. So today I'll be presenting on initial assessment of neonatal and pediatric respiratory care. So to begin with, we need to know what is respiratory distress is. This is the main topic what I'm dealing with. Respiratory distress, as you know, it doesn't really involve primary lung pathology. It could be because of some systemic issues as well, like sepsis or heart failure or metabolic acidosis, like dehydration or toxic ingestions, or primary lung pathology itself. So you have to know primary lung pathology can have different characteristics or signs and symptoms which we are dealing with. To overview on all this, we have to have general examination, which begins with inspection, palpation, percussion, and auscultation. So we'll begin with inspection. So to understand inspection is nothing but you have to look closely and examine the patient. You just have to look. That is inspection. So we are dealing with the face, nose, eyes, ears, throat, and mouth. So with the face, we have to look for nasal flaring and grunting and something called as micrognathia. If you see this, okay, you have a small chin and you have a large tongue which is obstructing the airway. So that is micrognathia, and I'll be dealing on nasal flaring and grunting. To inspect the eyes, we have conjunctival pallor. The meaning, when you have anemia, you will have some pale coloring below your eyes. You just have to let down your lower eyelids. So this is how it looks like. Ears, you have to inspect for bulging and inflammation of the tympanic membrane in context of otitis media, meaning inner infection, middle ear infections. So this can be seen mostly in viral upper respiratory tract infections. Inspecting nose for deviated nasal septum. As you can see, the nose, the septum is little deviated. This is usually associated with difficulty breathing. Nasal polyps is a benign, painless growth in the nasal passages, which is usually associated with atopy or cystic fibrosis. Inspecting the mouth, maybe you can ask the child to see how big your mouth is or how long your tongue is. So, or you can check for something called as central cyanosis, which is bluish discoloration of the lip and the tongue. So this is because of hypoxemia, that is low oxygen in the blood. Cleft palate is the congenital splitting of the roof of the mouth, and inspecting for throat with the help of tongue depressor to check for tonsillar hypertrophy, which looks something like this, which will indicate recurrent tonsillitis and airway obstruction. Inspection of the chest wall. We have Barrett's chest, where you see a normal chest in the second picture and the barrel chest in the first, the AP diameter of the chest is increased. We usually see this in asthma and COPD because we have air trapping in those cases. Pectus carneatum is a pigeon's chest where you have protrusion of the sternum and the ribs. Usually seen in syndromic patients, Noonan syndrome. Okay. Pectus excavatum is the sunken chest. If you see in this picture, it's a cave-in chest, sunken in appearance. Usually you can see in Marfan's syndrome. Harrison's sulcus, it is seen in pediatric patients who have poor control over asthma. Because of the repeated diaphragmatic tugging, they tend to adopt this type of chest. Kyphosis is the increased AP diameter, increased front to back diameter of the spine, and scoliosis is the sideways curvature of the spine. Okay, so anytime you inspect on the bedside, the first thing you have to review is the vital signs. So that can include heart rate, respiratory rate, saturations, temperature, blood pressure monitoring. So this has to be the first inspection to be done on the bedside. And any child with a respiratory distress will display non-pulmonary signs and pulmonary signs of respiratory distress. So non-pulmonary signs of respiratory distress could be these, like anxiety, fuzziness, irritability, decreased level of consciousness or unresponsive, or tachycardia. So pulmonary signs of respiratory distress are all of these. So we'll be dealing one by one. So tachypnea, it is, all of you know, an increased respiratory rate. So basically in pediatrics, when there is any problem that is interfering with the gas exchange, or if there is increased carbon dioxide production, the very first compensatory mechanism is to increase the respiratory rate. So that's a universal presentation of respiratory distress. We have age-related classification for respiratory distress, respiratory rate, to call it off. For newborn, we have 40 to 60 breaths, 1 week to 3 months of 30 to 50 breaths, 3 months to 2 years is 30 to 40, 2 to 10 years is 40 to 24, and more than 10 is 12 to 20 breaths per minute. Coming to the nasal flaring. So it is an essential way of increasing the size of the upper airway. So to some what extent we have higher resistance over the nostril for the airflow to get in. So by flaring the nose, the baby is trying to increase the passage in order to reduce the resistance. So we have a small video to be seen. Just a moment. You can see the noses.
Thank you, ma'am, for enlightening us. I would request Mr. Sharif Anam to hand over the memento to Ms. Umi Salma. Sharif, please do come. Salma to come up on the dais. Thank you. Moving on to our next topic, which is NIV, an Introduction to Mechanical Ventilation in Neonates by Ms. Mangal. Mangal has postgraduated respiratory therapy from Symbiosis University, Pune. She also has fellowship in neonatology, Forum, India. Currently, she is working as lecturer in BGS Global Institute of Allied Health Science. She has few paper publications. I would request Ms. Mangal to come over.
For the excellent presentation, I now request Ms. Bichula to hand over the memento to Ms. Mangal. Ma'am. The next talk for the day will be delivered by Mr. Sharif on initial assessment of respiratory care in adults. Mr. Sharif has graduated from Narayana Hrudayalaya. He has work experience of 6 years. He was initially working as a clinical coordinator at Saptagiri Institute of Medical Science. Currently, he is working as senior respiratory therapist at Sparsh Hospital, Infantry Road. Simultaneously, he is managing director of Breathe Care Health Services. I would like to call Mr. Sharif to the dais.